Hi everyone, welcome to NGR 367. Today we are continuing on deliverable 4. Diagnostic confirmation of delirium induced by UTI is strongly supported as the patient's clinical presentation and diagnostic findings aligned. The diagnosis involves a 2-year-old female who had a fever of 100.8, acute confusion, and laboratory confirmed UTI with positive and leukocyte, which are characteristic features of infection-related cognitive decline in an elderly patient. As opposed to young individuals, older patients, especially those with diabetes, are vulnerable to UTI due to neurogenic bladder dysfunction, immune sensors, and impaired urinary clearance. Remarkably, in the setting of the elderly, the absence of dysuria or costovertebral angle tenderness does not rule out UTI, as a typical presentation are very common. The diagnosis of acute viral pharyngitis is thus sustained by presence of pharyngeal erythema with a negative rapid strep test consistent with viral etiology. Moreover, new onset diabetic peripheral neuropathy corresponds with long-standing hyperglycemia and sensory deficit found bilaterally, being a well-known complication of chronic diabetes. Together, these diagnoses explain her symptomology but emphasize the need for further comprehensive investigation in elderly patients with coexisting conditions. The choice of UTI-induced delirium as the primary diagnosis is firmly grounded in Infectious Disease Society of America guidelines, which recommend that urinalysis and urine culture should be performed in an elderly patient with delirium, regardless of whether they have localizing urinary symptoms. Leukocytosis supports an infectious origin, though the UTI cannot be ruled out by the lack of costovertebral angle tenderness, as elderly patients often lack such localizing symptoms. Also, the confusion assessment method may be used to assess delirium formally, though clinical suspicion was enough in this case as the infection trigger was clear. The criteria of no fever, no exudate, no anterior causal cervical lymphadenopathy, and negative rapid strep test significantly suggest a bacterial cause for acute pharyngitis. Owing to the minimal possibility of group A streptococcus, and antibiotics are appropriately withheld, keeping in line with antimicrobial stewardship principles. The diagnosis of diabetic peripheral neuropathy follows the American Diabetes Association recommendation for the diagnosis and management of diabetic neuropathy, especially in those with any complaints of sensory loss. With decreased sensation bilateral in the lower limb, the patient presents distal and symmetric polyneuropathy, one of the main indicators of long-standing diabetes. Early diagnosis is important because neuropathy predisposes patients to foot ulcers, falls, and impaired mobility, primary concern in geriatrics. The case highlighting the need for elderly identification of diabetic peripheral neuropathy, especially in older adults who may not disclose their symptoms or dismiss their symptoms as expected aging symptoms. Peripheral neuropathy can develop insidiously in older diabetic patients, and recognize that these patients need to be assessed for this condition at every opportunity. In my practice, I will continue to perform routine neurological examination and monofilament testing for all diabetic patients over 65. Additionally, this case improved my understanding of the complexities of geriatric assessment. Older adults have multiple comorbidities and their symptoms can overlap, making diagnosis even more challenging. When I identified that the patient was confused, it was important to remember that the confusion may be due to a UTI and not necessarily indicative of cognitive decline or polypharmacy. For example, I have focused only on the patient's confusion without asking about her urinary symptoms. The underlying infection may have been missed. Overall, this case will be a reference point for me when diagnosing complex presentation in frail older adults. It solidified my knowledge about the use of both subjective information and objective testing for clear diagnosis and the importance of cultural competence. Knowing that the patient was Hispanic prompted me to include herself and her daughter in the diagnosis conversation, considering my linguistic and cultural as well as effective communication. Thank you.